everybody. Thank you so much for joining us today at ACC.24 Fits on the Go. Today we're going to be talking to Dr. Andrew DeFilippis, who is the director of the cardiac ICU at Vanderbilt Hospital. Thank you so much for being here.
Thanks for having me.
We're going to be talking about the MINT trial. You're the director of the cardiac ICU, and so I wonder what was the rationale behind the MINT trial and why you came up with this idea.
Yeah, so it turns out that anemia is common in acute myocardial infarction. About 20 to 25% of patients, given the criteria of the MINT trial, have a hemoglobin less than 10. And while transfusion strategies and thresholds are established for a lot of other patient populations, really there was very limited data in patients with acute MI and anemia. And it was in this context that the MINT trial was done.
That's fantastic. And what considerations did you have in mind when designing the trial? Inclusion, exclusion methods?
Yeah, so you want to represent a patient population that is criteria so that you could have a patient population that could be easily recognized by clinicians, and at the balancing that with a patient population criteria that allows you to be treating a specific disease. In the MINT trial specifically, we made the decision to enroll both type 1 myocardial infarction and type 2 myocardial infarction. Both myocardial infarctions, but of course the pathophysiology of type 1 and type 2 is different. So we account for that by enrolling both and pursued a pre-specified subgroup analysis, and that's what we presented this year here at ACC.
Oh, and would you mind telling us a bit more about the results of that pre-specified analysis?
Yeah, so first, just a little context of the overall MINT trial. What we found were that patients with acute myocardial infarction and anemia randomized to the restrictive transfusion strategy had a numerically higher rate of the primary outcome of death or MI at 30 days of 18.2%, compared to, let me say that again. Overall results of the MINT trial, which have been published, showed us that patients with acute MI and anemia randomized to the restrictive transfusion strategy had a higher absolute and relative risk of the outcome at 30 days of death or MI. But this was with a confidence interval that started at 0.99. And so the p-value was 0.07. So really not definitive evidence that a restrictive transfusion strategy was harmful in these patients, but really did raise concern that a restrictive transfusion strategy may not be safe in these patients with a confidence interval starting at 0.99. From there, we knew that type 1 and type 2 MI were different, and potentially, given that difference in pathobiology, that they would respond differently to transfusion. And so the objective of this subgroup analysis was to see how patients with both type 1 and type 2 MI responded to a restrictive versus liberal transfusion strategy. What we found was fairly similar to the overall results in that type 1 MI patients had a lower relative risk and a lower absolute risk when randomized to the liberal transfusion strategy as compared to the restrictive transfusion strategy. While type 2 MI patients, we didn't see any difference between the restrictive and liberal transfusion strategy. However, with any subgroup analysis, there is statistical testing to see if these differences were just chance alone or if there was truly, evidence that the intervention, in this case transfusion strategy, was different based on MI type. And for that, our test of interaction was not significant with a p-value of 0.16. So, somewhat conflicting evidence. We had, relative risk, and when we looked at the transfusion strategy in type 1 and type 2 separately, we saw that the liberal transfusion strategy was superior to the restrictive in type 1, no difference in type 2, but the test of interaction's not definitive that this is a true difference in the treatment. And so it's hard to know exactly what to do with the data. The next thing I would point out is that we had safety outcomes like heart failure. Are we overloading these patients? And there we saw no difference between the restrictive and the liberal transfusion strategy, regardless of if you had type 1 or type 2. So in totality, you have some evidence suggesting that this restrictive strategy may not be the right approach for patients with acute MI and anemia, particularly in the type 1 population, but it's not definitive. I think everyone's gonna have to look at the data and make the decisions themselves. For me, it's changed my practice. Prior to the MINT trial, I used a restrictive transfusion strategy in patients with acute MI and anemia, and now, although the data is not definitive, with no signal of harm from a liberal transfusion strategy, certainly account for all the individual patient characteristics, but I would tend to now feel safer with a liberal transfusion strategy, particularly in patients with type 1 MI.
Well, thank you so much for going over that. And speaking of practical aspects, in the trial, they had about 1 to 2 units of blood that was transfused, correct? Do you have a certain amount of units that you like to do, or do you have a target hemoglobin that you want to achieve? Sometimes to get that from 7 to 10, you have to do a bit more.
Yeah, that's a great question. So the trial design was 1 unit of packed red blood cells at a time. And if you were in the liberal transfusion strategy, it was 1 unit at a time, checking the hemoglobin in between until you got to a hemoglobin of 10. And then the hemoglobin checked at least once a day. And if it's below 10, to transfuse again. The liberal strategy, up to the physician, whether you wanted to have that breaking point at 7 or 8, and then just to maintain above 7 or 8. Your question about to where to go is a great one. And we have ongoing analyses to hope to answer that question. Right? Where is that breaking point where patients are protected? Do we need to get all the way up to 10, or is there somewhere in between? And more to come on that question from the MINT trial.
Perfect. Because I did see somebody being transfused 5 units just to get to 10, and obviously they did not have a great outcome. So that's why I wanted to clarify that. And I just wanted to ask one more practical aspect. I believe, if I'm correct, for the PCI performers, having a transfusion after their PCI actually counts as a poor outcome. So I wonder, do you think that's going to influence clinical practice or uptake of transfusion in this population or not?
Yeah, we had to tackle this question with the trial. When we were, engaging sites to participate in the MINT trial, they astutely pointed out that it is a negative as far as quality metrics if you receive a blood transfusion after going to the cath lab. And that it was something that absolutely hindered enrollment. It is an ongoing discussion. Clearly these data are being collected, and we're trying to affect outcomes in the treatment of these patients. But in the setting of a randomized trial, this was an impediment. Now extending to clinical practice, I agree with you that this is going to have to be an active discussion about whether that still should be a quality metric in face of this new trial data showing that there is not a safety concern with giving a transfusion, but there may be a safety concern with withholding transfusion in anemic patients that are having an MI.
Well, thank you so much for going over the details of the trial with us. To watch more videos like this, please check out youtube.com/FITsOnTheGo and follow us on X, FITsOnTheGo.